A very good evening and a very warm welcome to all the doctors over here. I, Nikunj Thakkar, on behalf of Sanofi, take this great pleasure in initiating this very special international speaker program. As you all have seen, Sanofi's commitment to allergy has been tremendous and it's been growing over a period of time, and our endeavor is to maximize this further. We've been doing multiple international symposias and making sure that we reach out to as many number of cities in India so that the whole participation from all the HCPs increases over a period of time. In line with our commitment and our endeavor, this is once again a very special year when we take this initiative of bringing ARIA 2017 to India, and with the speaker none other than the chief of ARIA himself, Professor Jean Bousky from Montpellier, France. I take great pleasure in inviting all the audience over here in the live center at Kolkata. Also, it's my great pleasure to invite and also welcome multiple centers that are connected today. To be very specific, we have about 40 centers connected across India. So we are talking about almost 500 HCPs connected to us through this webcast centers as well on this particular date. To take forward the proceedings, now I would like to call my colleague Dr. Rahul Joshi and help us to take you through the program further. Thanks.
Thank you, Nikunj. A very warm welcome from my side to everyone present here and also at the 40 webcast centers spanned across the country. What I'll do is I'll introduce all the 40 chairpersons. A very warm welcome to all the webcast centers across the country. From Agra, we are connected with Professor Dr. Dharmendra Kumar, Professor Dr. Rakesh Bhatia, Ahmedabad, Dr. Rajesh Vishwakarma, Akola, Dr. Ram Heda, Amravati, Dr. Baban Belsare, Amritsar, Dr. Dinesh Sharma, Asansol, Dr. Lalit Ray, Bhopal, Dr. Rahul Agarwal, Bhopal, Dr. Ashish Jain, Bhubaneswar, Dr. Arijit Mohapatra, Bilaspur, Dr. R.D. Pathak, Burdwan, Dr. Manoj Mukherjee, Calicut, Dr. C.P. Roff, Coimbatore, Dr. A.R. Ali Sultan, Darbhanga, Dr. B.K. Singh, Dehradun, Dr. Ajay Sharma, Dhanbad, Dr. B.B. Sahani and Dr. B.K. Thakur, Gorakhpur, Dr. Y.C. Yadav, Dr. Nadeem Arshad, Gurgaon, N.P.S. Verma, Guwahati, Dr. S.B. Fukan, Gwalior, we have two chairpersons, Dr. A.K. Bhalla and Dr. K.K. Tiwari, Haldwani, Dr. Gaurav Singhal and Dr. Vaibhav Kuchal, Indore, Dr. Rajendra Mehta, Indore, Dr. Samir Nivsarkar, Jalgaon, Dr. Sunil Thatte, Kalyani, Dr. Tapas Datta, Latur, Dr. Shyam Somani, Meerut, Dr. Virottam Tomar, Murshidabad, Dr. Soumitra Ghosh, Nagarkoil, Dr. Mohammad Miran and Dr. Muthu Kumar. From Patna, we are connected with Dr. Ashok Shankar Singh and Dr. Chandrasekhar. From Perinthamanna, we have Dr. Girish Raj. From Raipur, Dr. Rakesh Gupta. From Rajkot, Dr. Ashok Mehta and Dr. Kamal Parikh. From Ranchi, Dr. Raghav Sharan and Shyamal Sarkar. From Salem, B.K. Premnath. From Siliguri, Dr. Anandabrat Bose. From Surat, N.J. Shah. From Thanjore, Dr. A. Jesudas. From Trichur, Dr. P.T. Arun Kumar. From Trivandrum, Dr. Santosh. From Varangal, Dr. P. Ramanjaneyulu. So these were all the webcast centers and their respective chairpersons. There's a request I would like to make out here to all the chairpersons in the webcast center to please initiate the discussions from your end once the talk is over and invite questions so that our panelist and Dr. Professor Jean Bousky can answer them. Once again, welcome Kolkata. I would like to introduce the first chairperson for tonight, Professor Dr. Barin Roy Chaudhary. Basically, it doesn't require any fond introduction, but as a formality, I would like to state that he is the visiting physician, House Ear Institute, Los Angeles, USA, fellow awardee, the fellowship honoris causa of the West Bengal State Medical Faculty by Honorable Governor of West Bengal, fellow of Indian Academy of Otorhinolaryngology and Head Neck Surgery, with having over multiple national, international publications, original research papers, and also patents. He has innovated. This is something which is extremely important, and we as Sanofi appreciate the innovation which is happening at the space of HCPs. He did a 3-flap tympanoplasty for safe CSOM, a simple and a very sure success technique called as 3S technique. Neostepidotomy for otosclerosis, piston through the center of cartilage shield with tympanoplasty in unsafe CSOM where only mobile stapes foot plate is present. Modified septoplasty for deviated nasal septum, a new technique for better outcome. Sir has been called at multiple locations across the globe to explain and conduct live surgeries so that the fellow otorhinolaryngologist and otologist can benefit. The next chairperson for tonight is Dr. Parthasarathi Bhattacharya. He is a pulmonologist, MD, DNB and DM in pulmonary medicine, currently working as chief consultant at the Institute of Pulmocare and Research from 2004 till date. Sir has a very rich research experience again. He is the senior research fellow of CSIR during the postgraduate fellowship at PGIMR Chandigarh. Serious engagement in the research after forming IPCR in 2000, which has resulted into global recognition of the institute as CIRO for 2006 onwards. He has credited over 35 publications in peer-reviewed journals, including the publications in the CHEST and ERJ. He has 6 Indian patent applications to his name. Collaboration with SSKMH and PGIMR Chandigarh, Indian Institute of Chemical Biology, Calcutta University and Institute of Technology are some of the very much credential and talked about points in Sir's career. Completing 3 projects, 2 being funded by Department of Science and Technology from the West Bengal. At present heading at least 11 projects at IPCR and collaborating with 3 different institutions. Innovation of a procedure and modalities of the treatment is what is his areas of interest, and he obviously excels in that. With that, I would like to now call upon Dr. Barin Roy Chaudhary to please come up on stage and introduce Dr. Jean Bousquet and take the proceedings forward. Thank you and welcome once again.
Thank you, sir. Good evening, everybody. It is a pleasant task put on me to introduce our lecturer, Professor John Bousquet. You have already heard about him, and whatever we say nowadays, ARIA, and he is the chairman of that ARIA. So we are lucky to have him today in this evening amongst us to deliver a lecture on ARIA. His trainings are, he did MD in November 1979, PhD in pharmacy in November 1979. Training in allergology and thoracic medicine in an university, Montpellier University, and he has many posts in this University of Montpellier in France. And there are, actually he is a chairman of WHO Global Alliance Against Chronic Respiratory Disease. And his main lectures and publications, 725 original publications in English, in peer-reviewed journals and referenced in Medline. He was an editor, European Respiratory Review and Respiratory Society. He was an editor in 2003, 2010, an allergy official organ of European Academy of Allergology and Clinical Immunology. The second journal of allergy. He is associate editor 1992 to 2002 on allergy and clinical immunology news official organ of WAO. He is a member of the advisory board of clinical and experimental allergy official organ of the British Society of Allergology and Clinical Immunology 1999 and to 2004. He is a member of the editorial board of American Journal of Respiratory and Critical Care Medicine. He is the Journal of the Allergy and Clinical Immunology in 1989 to 1993. He is a clinical experimental allergy in 1988 to 1999 and is a member of the Biodrugs in 1992 to 2004. And he is an international Archives of Allergy and a member of the International Archives of Allergy and Applied Immunology in 1995 to 2004. And he was a member of the editorial board of International Allergology, the official organ of the Japanese Society of Allergology in 1997. His area of interest and research is on airway remodeling in asthma. It is very important, and the relationship between asthma and rhinitis as comorbidities. So with this short resume, I request Dr. Buski to deliver his lecture on ARIA. Please come on the dais. Please, thank you.
Ladies and gentlemen, I need to be pinned up because I don't have my pin yet, but it's coming now. So it's my great pleasure to be in Kolkata today and to be in line with 40 different centers. Well, I think this is the first time I'm in line with so many centers. So this is wonderful. Today I would like to discuss with you ARIA. But I would like to discuss it not in the way of a guideline, but what could be the future. Well, I started ARIA in 1999 because I had a patient in 1990, and this patient had severe asthma. So I treat the patient for asthma, oral corticosteroids and then inhaled. And when I saw the patient a month later, asthma had disappeared. But the patient told me, "Doctor, I am not satisfied. How can it be that you cure asthma or treat asthma properly in a patient and the patient is not satisfied? Because I have rhinitis." And from them I said, well, look, probably there is something. And it's clear there is something. So we did epidemiologic studies, I will show you that. We did biopsies in the nose and the lower airways, and then we did ARIA. So ARIA is not coming just because we wanted to do it, but because there is a patient need. So today I would like to discuss with you United Airway Disease. Yes, but, because you will see that there are some problems sometimes. Second, ARIA between 1999 and 2016, but we're in 2017. So we need to move, and we cannot stay the same. So now we went from guidelines to an integrated care pathway, and this is MASC, MAGVIA, ARIA, Sentinel Network. Well, that's good, but we need an algorithm for the treatment of allergic rhinitis, and we'll show you what we have proposed. And finally, I will end by future therapies or better management. So let's start by United Airway Disease. Yes. Well, this gentleman is Dr. John Bostock, and like me was a pharmacist and a physician, but he described hay fever. And he described it 200 years ago. And what he said, every year in June, I have conjunctivitis, rhinitis, and asthma. So the links between the lower and the upper airways were described the first time there was a description of hay fever. Can I ask that it's very cold on the back, and I don't want to get a cold after that in the hot weather of Calcutta. This would be a bit surprising if I come back to France saying I have a cold. Then we did a study which was in the European Community Respiratory Survey in 16,000 individuals. This was a pan-European survey, and we showed two things. First of all, that there was an significant increase in asthma in allergic rhinitis by comparison to people without, but also in non-atopic individuals. And this was the first time we found, or someone found, that there was a relationship with non-allergic rhinitis. So it is something on the system between the nose and the lower airways rather than allergy. With the same study, we assessed the prevalence of asthma in rhinitis. Well, it is clear, when there is no rhinitis, there is almost no asthma. When there is seasonal rhinitis, 5%. When you have perennial rhinitis, 10%. And when you have both seasonal and perennial rhinitis, what we call persistent rhinitis, we have almost 18%, indicating that that asthma is not in all patients, but it is mostly in the most severe rhinitis patients. There is another study from Dr. Guerra in the States, and then he showed that asthma was more common in moderate and severe rhinitis again. So there is a link between the severity of the disease and the prevalence of asthma, and also its severity. Now this is another interesting study, and this study was done by Professor Price. What he did, he assessed almost 27,000 patients. Those with asthma alone at an hospitalization rate of 0.45, and those with asthma and rhinitis of 0.76. So having asthma and rhinitis is a different phenotype. So yes, there is United Airway disease, but, well, now I'm going to show you what we're doing currently. Currently we're using cell phones, and we're using a vision log scale of not bothersome, extremely bothersome, and we ask 4 questions. The first one is, how much are your allergic symptoms bothering you today? Nasal symptoms, ocular symptoms, asthma. So first of all, is there a correlation between global allergy and rhinitis? Well, here you have 42,000 days. So it's not a small study. It's in 42,000 days. And the correlation is extremely high. So yes, rhinitis is associated with the severity of the disease. But what is asthma and what is conjunctivitis? So with the same study, we assessed the global assessment between 0 and 100, and here this is the prevalence of subjects. So as soon as you have global symptoms, you have rhinitis, and there is a plateau for mild symptoms. Then this is very important. This is work productivity. Work productivity is impaired more by rhinitis than asthma, but it is more impaired even by the global symptoms. So once again, there is a correlation between all the organs around the nose. This is conjunctivitis and this is asthma. And we can find that in the very severe days, almost 90% of the people have asthma as well as conjunctivitis and rhinitis. However, there is a phenotype here with very high levels of rhinitis and no asthma at all. So the picture is more complex than we may think. Now you can tell me, okay, this is prevalence, what about severity? Well, severity is even better, because look, when the disease is getting more severe, there is almost a direct line with rhinitis. And it's about the same for asthma, for work, and for, the nose, except for the very severe people where asthma is not present. So there is a new phenotype which should be investigated. It is rhinitis without asthma, and possibly the treatment may differ. Well, you asked me a question, what are the differences between the nose and the lower airways? Why is there no remodeling in the nose, whereas there is remodeling in the lower airways? Well, we have done a very big study. It was a 16 million euro grant, so in rupees it's with one more zero, something like this. And what we did, we assessed multimorbidities, and we found that multimorbidities were associated with mesodermal origin in the embryo, because this is the T2 response. And what we found as well, it is that asthma is endodermal and rhinitis is ectodermal. There is no remodeling in rhinitis, there is a remodeling in asthma. Well, the physiology is doing well, because if by any chance you have remodeling in the nose, then no one could breathe in this room with the nose, because with the amount of pollution, with the amount of anything you have in Calcutta and elsewhere, then no one could breathe. So it is because we don't have remodeling in the nose that we can still breathe. So the human nature is extremely good. Now, ARIA between 1999 and 2016. Well, why did we do ARIA? First of all, because we wanted a state-of-the-art for the specialist, the general practitioner, and healthcare workers, as well as patients, to update knowledge of allergic rhinitis, to highlight the impact of allergic rhinitis on asthma, to provide an evidence-based document on diagnosis and treatment, and to propose a stepwise approach. But very importantly as well, we wanted to assess the magnitude of the problem in developing countries. 20 years ago in India, rhinitis was not a problem. Today it is a problem. So it has increased tremendously within the past 20 years. So we wanted 20 years ago to assess what will be the future, and we did that with the International Union of Against Tuberculosis and Lung Disease. We published the first paper, which was the ARIA workshop report in collaboration with WHO. So we did that with WHO. They were not interested very much in rhinitis, but we told them, well, look, we think that rhinitis will become a major problem everywhere in the world, and it is now. So we had also a translation of the pocket guide in 52 languages, which is quite extensive. We have Mongolian, we have Indian, we have many others. Well, in India we have Hindi. Sorry, I know that we have, how many languages? 300 and something like this. So, 17 major. So we just kept the major one. And then we did an update. But we were not satisfied by that, because you need to change. You need to change the evidence-based system. And we went from a very simple one, which was the available one in 2000, to a much more complex one, which is the grade evaluation. The grade evaluation assesses the quality of the studies, what are the results, the efficacy, the safety, and the cost. So it's more complex than simple saying effective or not. And this paper is quite important because it is coming with a supplement of 560 pages. Well, I don't ask you to read that, but if you think that one of the statements is not correct, then you can go to this document and check why we had this statement. And I think that this is very important to have the evidence listed. So what is the evidence? I took 3 examples. The first one, should oral H1 antihistamines be used for the treatment of allergic rhinitis? We had 2 things. We had recommendation and suggestion. We recommend, in patients with allergic rhinitis, we recommend new generation oral H1 blockers that do not cause sedation and do not interact with cytochrome P450. This is strong. We suggest these drugs that cause some sedation and or interact with cytochrome P450. Is this important? Yes, it is, because not all drugs are the same. And this is a study we performed in 1998 in 820 patients. What we compared placebo in green with 2 doses of fexofenadine and cetirizine. And what we found that efficacy was about the same with the 2 dosage and the comparator. But there was a significant increase in sedation in the cetirizine group, whereas this was not seen in the placebo or in the fexofenadine groups. So the recommendation would be suggest for cetirizine or levocetirizine and recommend for fexofenadine, desloratadine, for example. Now this is a question that in India is a problem because in fact I know that many people are treated by OTC first generation antihistamines, and we recommend not to use that because of safety problems. Safety, it is sedation, it is urinary tract problems, so there are many problems associated with sedative first generation H1 blockers. We then went to intranasal corticosteroids, and we were able to differentiate adults and children. In adults, it is undisputable, intranasal corticosteroids are very effective. In children, they are less effective, either because it is difficult to monitor the treatment in children or to assess very well the treatment in children, or because they are less effective. ARIA has been accepted by governments. We have 2 here, Singapore and Brazil, but we have now almost 15 governments which are using ARIA. So it is a trademark, now. It is not any longer a guideline, it is something which is fully accepted. And now we have the new ARIA guidelines. I'm not going to discuss them in detail because I want to go further. These new guidelines are comparing different drugs, and it is more difficult with grade to compare 2 drugs than to compare a placebo and a drug. So these guidelines have been recently published, but I think that we need to be a bit more cautious. ARIA is in Belgium now. It was in the US, but Dr. Larry Gross died and now it is in Belgium. Well, now I'm going to make a different part of my presentation. Guidelines are very important. The problem is that they are seldom used. You probably use ARIA, but how many GPs in your country know ARIA? How many GPs in your country are using ARIA? 2%? It's a maximum. So we need to do something different. And we decided to go from guidelines to integrated care pathways in order to help patients better. So first of all, this has been recently published. It is now care pathways implementing emerging technologies for predictive medicine in rhinitis and asthma across the life cycle. So it's not any longer a guideline, it's an implementation strategy. And for this, we're using cell phones, because it would be too complex to use it in paper. You can do it in paper, but using cell phones is much better. And now we have the expertise of about 12,000 subjects. So first of all, this is a project which has been proposed by the European Union and WHO. So it is not simply a project we are coming from experts to policymakers. We have experts to policymakers this size, but we have also from policymakers to experts. And we are trying to join both of that. First of all, this is an EU project, and it is on the Innovation Partnership on Active and Healthy Aging. Why active and healthy aging? Because myself, I'm 70, I have rhinitis. And many of us with rhinitis will get to old age. And in this case, we do not know exactly whether the phenotype is the same, whether the treatment is the same. So we need to better assess rhinitis and asthma in old age people, and this is what we're doing here. So this is one of the key slides of my presentations. Patient allergic rhinitis symptoms even with asthma, self-medicate. Most patients, when they have symptoms, take what they have in their shelves and take a pill or take a puff in the nose. Then, not possibly in India, but in many countries, they go to the pharmacist. Why? Because the pharmacist can give a medication right away, whereas it takes 5-10 days to get a prescription from the physician. But the people want to get treatment immediately. And then they usually go to primary care, then to the specialist, and if everything is not going well, they go to emergency care. What is important it is that we have developed tools, I will show that to you later, both for the patient and the healthcare professionals. And these tools are interoperative. So now, what is the algorithm for the treatment of allergic rhinitis? First of all, pharmacotherapy. Well, what we did, we had a consensus meeting with all these people, but the full group is 250 people, and we based a clinical decision algorithm in adolescents and adults with allergic rhinitis. Well, you are going to see it's a bit complex, but what we have done now, it is integrated in an electronic clinical decision support system. And what we said, well, in general practice or pharmacists, many people are untreated. In specialists, all the people we see are treated, or at least have received the treatment. So we differentiated between untreated and treated people with symptoms. We use the visual analog scale because it is a very powerful tool. It's a tool powerful in pain, but it's a tool powerful in rhinitis. So when I was seeing patients, because now I've retired recently, I was drawing a line and say, where are you? And when the patient was showing with his finger or with a pen, then I knew where the patient was. If the visual analog scale is less than 5, then you initiate the treatment and it can be any treatment. If the visual analog scale is over 5, then you can use many treatments, but you often need to use intranasal corticosteroids. So you know it's very simple. So then you reassess the treatment daily. But in fact the patients, and I can tell you that because we are testing this algorithm in practice, then we were able to confirm that people change their treatment daily depending on the symptoms. So if the visual scale is low, then you can stop the treatment, but the patient will do it. If the visual scale is still high, then we ask to step up the treatment according to what we have said before, and then to consider two things. First of all, an ENT consultation and immunotherapy. If you have treated symptomatic patients, so if the visual analog scale is less than 5, I think that this will change because we are seeing that it is a bit too complex. People usually stop their treatment. And if they are not well, you need to step up the treatment, and in this case, you need intranasal corticosteroids or intranasal corticosteroids plus azelastine. This is really what we need to do. And then, again, you reassess the treatment, but since we are doing this in an electronic form, it is very easy to be done. Much easier than for the patient. And finally, if the patient still has symptoms, with the maximum treatment, first of all, assess compliance, because most patients do not take their treatment and they tell you, I am not well, doctor. And I will show you how to handle this with an electronic system. And then you consider allergen immunotherapy and a referral to the ENT doctor. So you see, we are going far beyond a simple guideline. We are going to something to help the physicians or the healthcare professionals to manage the patient. Well, there is a drug that we don't have in Europe, and this drug has been made in this country. It is montelukast and fexofenadine fixed dose combination. The company assessed the efficacy by comparison to levocetirizine fixed dose combination and montelukast, and they found that there was a significantly better efficacy with montelukast fexofenadine than with montelukast levocetirizine. When there is a single study, it's not sufficient. So what they needed was to get a second study, and they found that the same effect occurred with a very big p-value, 0.003. So it is clear that this new treatment, which has been made in India, is quite effective, and I am delighted to say that there are two big studies which have shown that. Well, I'm showing you this helicopter because it is the only one which is able to do a looping. But doing a looping, you need a clinical decision system which is electronic. A pilot cannot do it, because remember that if during the looping is making a problem, the helicopter crashes. And we are using the same company to have the algorithm of ARIA. So we have an algorithm which is close to the helicopter system. Now immunotherapy. Well, immunotherapy, it's complex because you have two types of immunotherapy. One is subcutaneous, the second is sublingual. Subcutaneous immunotherapy, well, I'm sorry to say, but we tested that in 2011. There have been not too many studies in SCIT published since then, and most of the studies are not satisfactory in terms of methodology, because many are with per protocol analysis instead of intent to treat analysis. However, the SLIT immunotherapy was better. And it is far better because now you have many studies which have shown convincingly that sublingual immunotherapy low dose is not better than placebo, high dose is far better than placebo. This is for grass pollen with a French product. This is for ragweed pollen for an American product. So FDA and EMA approved both drugs for ragweed and for grass. So there are only two pollens accepted by EMA and FDA, and they are in sublingual immunotherapy. There are also studies from two companies again, showing that there is a significant improvement of 2 doses of immunotherapy by comparison to placebo, and this is for the exacerbation of asthma. And it's also very interesting to see that this product has now been approved both by European Agency and the FDA. But for the European Agency, I'm delighted to inform you that here the indication is for persistent, moderate to severe house dust mite allergic rhinitis, and this is the classification of ARIA 2000. Despite the use of symptom relieving medication, and this is the recommendation of ARIA 2008. So EMA has taken the ARIA guidelines to approve a medication. Finally, do we need future therapies or better management? Well, future therapies is this, and we did that again with an EU grant. So this is the modern approach of medicine. Endophenotype network of complex diseases. Well, this is complex, you know. And then you have the whole genome sequencing. So, if I am asking to a drug company, is this the future, they will all say yes. And I will ask them now, when do you have the next product? In 2025. So we cannot wait until 2025. And even though I have done that in the EU grant I discussed with you before, we think that now the future of allergic rhinitis and asthma is the finger approach. Not to put the finger into the nose, no. Just to put the finger on a cell phone. And this is appropriate because it is easy to do, and we have done that now in 22 countries. We again use this integrated care pathway, but as I told you, we have for the nose, for the patients, the cell phone, the pharmacist and the physician who have the tablet. So now everything is electronic. This is a very interesting slide. Why? Because in 1 minute you go from your cell phone to your computer and you can print for your physician the exact file of your data for 1-2 years, whatever since you started the project. And you can see here the severity of rhinitis, this is me, and the medications I was taking. So I can show to my doctor, well, doc, this is what I have. So you will see what the patient took as a medication, because patients tell you, I am not well. And then it takes you some time to understand that it is because of compliance or because of severity of the disease. With this system, it takes just a single, you read, if you have 60 days of the 3 months, then you know, or the 2 months, then you know that the patient is compliant. This is in the countries. So I want to show you 2 results. The first one is, well, we have the symptoms of the patient and how it affects. It affects my sleep, restrict my daily activities, restrict my participation in school or work, and are troublesome. So you see, very simple. And with that, we already have a paper. And the paper is the following. You have troublesome symptoms, nasal obstruction, and ocular symptoms. And you have work and school productivity, daily activities, and sleep. You see that when it's not troublesome, and it is troublesome, you have an increase of the 3 components. When it is nasal obstruction, you have a big increase in sleep. But for conjunctivitis, you have an increase in work, an increase in daily activities, and no increase in sleep. So we are able to identify the phenotype of patients with this very simple approach. This was just to show you that it works very easily. Now I am going to ask you a question. Well, we have done the visual and I'm going to ask you to vote. So the patient is well when he has no treatment, a single treatment, multiple treatment. I repeat, the patient is well when he has no treatment, a single treatment, multiple treatment. Who is voting for no treatment? No one? Ah, 1 person. Only 1? 2. Only 2? 3. And here? 5. Good. Now, the patient is well when he has a single treatment. Vote. 1, 2, 3, 4, 5. Okay. And when he has multiple treatment? Okay. We're going to see the results. This is in 25,000 days. Well, these are 3 intranasal corticosteroids, 3 H1 blockers. Well, patients are better when they have no treatment. And they are worse when they have multiple treatment. The guidelines ask you to increase the treatment to get control. In fact, patients take more medications when they are not controlled. So you see that this simple treatment makes it simple to assess the patient and to give results. Well, ladies and gentlemen, I think that I've shown you that the ARIA guidelines are now an implementation strategy using mobile technology. And this is, I think, the next step with the finger approach to make a better management of allergic rhinitis and asthma. Thank you.
Thank you so much, Professor Buski. I think it was a very great session and insightful for all of us to start with the history of ARIA, the way it has evolved, and finally ending with what could be the future in terms of a technologically driven way of managing the allergic rhinitis. I'm sure all of you over here and a lot in the webcast centers have a lot of questions. So while we all decide what questions to be asked and while we receive the webcast center questions as well, I would seek your attention for a small commercial break over here, and further that we'll start with the Q&A session.
Hello and welcome to the Health Hour. This is your host Bharti Kumaria, bringing you the latest updates from the health world. To begin with, the newest buzz in the market is GST. From 1st of July, GST has affected various sectors in different ways, but we turn our spotlight on the health sector. It is expected that GST would have a constructive effect on the pharma sector. There are hopes to witness a promising development in healthcare. Moving on, monsoon has set in India. Torrential downpour, particularly over Mumbai, Delhi and parts of Gujarat, has affected the cities along with its people. And with the rain and increasing pollution, allergy season has set in. Rain boosts allergens like pollen and mold, causing runny noses, thus triggering the condition of allergic rhinitis. Ignoring symptoms like sneezing, nasal itching and obstruction can impact quality of life and hamper day-to-day activities. We interrupt this bulletin with the breaking news. Reports have just come in that pharmaceutical giant Sanofi has crossed yet another milestone. For the very first time, Sanofi's hugely popular anti-allergy brand Allegra M has been endorsed for its quality and innovation, and the reports are published in the renowned Indian Journal of Pharmaceutical Sciences. Allegra M, the #1 fexofenadine montelukast drug, is used to treat persistent allergic rhinitis. The published reports talk about the bioequivalence of this combination. Over the years, Sanofi constantly innovated and improved upon Allegra and developed Allegra M in 2013, the first ever bioequivalent bilayer tablet. This publication is a testimony to this remarkable feat. The Indian Journal of Pharmaceutical Sciences has recognized this very innovative spirit. And for more on this breaking news, let's have someone from the house of Sanofi who has developed this formulation of Allegra M, Dr. Praveen Kullar from Goa Development Center. Dr. Kullar, welcome to our show and congratulations. How do you feel on Allegra M's endorsement in Indian Journal of Pharmaceutical Sciences?
I'm extremely delighted for such an endorsement and high quality results done at a CRO approved by US FDA, and we got a perfect matching with the individual reference product.
Can you tell us more about Allegra M's manufacturing process and how you were successful in developing such innovative and high quality standard formulation?
Allegra M is developed by innovative team using a very innovative granulation process. Fexofenadine granulation is done in an inert gas atmosphere. Montelukast granulation is done in a very selective light conditions. Innovative bilayer technology is used to get the most stabilized formulation.
Dr. Kullar, please share your insights on how Allegra M is better compared to other molecules in the market.
Allegra M has got perfect dissolution mapping compared to the reference. Allegra M also has a low sulfoxide content as compared to the other brands.
So can you tell us your mantra on commitment towards quality?
We manufacture Allegra M in a EU GMP facilities using a very strict in-process controls and also validated processes. All the raw materials come from a highly qualified vendors, and the goodness of two reference products in one is going to give enhanced patient compliance.
Thank you, Dr. Kullar, for taking the time out to tell us more about Allegra M. Also, I would like to congratulate the Sanofi team on this wonderful achievement. So be rest assured, as now if it's about quality and innovation, the answer is Allegra M. On this note, this is Bharti Kumaria signing off. Stay happy, stay healthy, and remember, when you think of trusted anti-allergy drug, think Allegra.
Thank you everyone. for a patient listening, and we take a real pride in this. And just for an iconic representation of the same, I would like to call upon Professor Dr. Buski, Dr. Barin Roy Chaudhary and Dr. Bhattacharya to please unveil the same.
Thank you.
I would like to invite Professor Dr. Buski, Dr. Barin Roy Chaudhary and Dr. Bhattacharya on the stage for taking up the question answers.
Please.
Yeah. So right at the beginning, when we said that we are connected to more than 40 centers, we have questions, flooding in to ask to Dr. Buski and our esteemed panelist. In the meanwhile, if there are questions from the audience sitting here at this very center, we are now open for questions.
Yes.
Right. Can we have some mics over here?
Microphone, please.
Microphones?
Yes.
I have a very small question to start with. It's very illuminating to see VAS for disease assessment by the patient himself. And why don't you integrate VAS for asthma and allergic rhinitis together? Because these two problems, they always remain together, almost always.
Yeah.
And that would be far better, I believe, than if you just do it for allergic rhinitis, not for asthma.
Yes, well, in fact, we have tested. No, I have the microphone. We have tested the VAS for allergic rhinitis for asthma in Japan, in 27,000 Japanese, and it correlates very well with the control of the disease. So I think that two VAS, how is your asthma, how is your rhinitis, and then you see exactly how the patients are. So for me, it is a simplification of the system.
Yeah, I use asthma control test.
Yes.
So do you think it is, I think it will be easier than asthma control test if the VAS really works.
But what you should do eventually is to take 100 patients, to do both, and to correlate. And this is a paper.
Sure.
Dr. Buski, please. Have you ever come across any case of asthma only, not having any allergic rhinitis?
That's a very,
Only asthma the patient is having, but no allergic rhinitis.
and that's very interesting, because up to recently I said this does not exist. And in fact, we have an enormous epidemiologic study in 44,000 children at birth, followed up to 16 years. And we found that some few patients have asthma without allergic rhinitis, but the phenotype is totally different. In fact, these patients have probably transient asthma. If at 2 years of age you have asthma plus rhinitis plus multiple allergies, you know that this child will have asthma and rhinitis across the life cycle. And those with asthma alone will likely have a disappearance of asthma. So there are two different things. However, there is a third component, which is air pollution and smoking, because then some people have a mixed COPD, asthma and rhinitis.
Is there any question from other centers?
Yes.
So
there are.
can I ask one
Yes,
before
yes,
that?
please go ahead.
Yes.
So we can easily look at the nose, and the symptoms of rhinitis can be very easily picked up. Sometimes asthma is missed. I have found 20% of asthmatics in my practice are actually missed,
Yes.
unless lung function test is done. So what I'm asking, looking at the rhinitis component, can you anyway have an idea about the severity of the asthma and the duration, or say kind of remodeling already been there in asthma?
So yes, the remodeling is present at birth. And there are many studies showing that children with low lung function have severe asthma later. So it's clear that the endodermal component exists. And there is a study which has been published by the Inner Asthma City group in the JCI in October 2016, and they showed that multimorbidity, allergic rhinitis and IgE multimorbidity and low lung function is the severe asthma phenotype. So yes, it exists, and I hope that you will read the paper I'm now writing that exactly give this example.
So there is one question here from Dr. A.M. Saha. Sir is right here. He has two parts to this question. This question is about the combination of fexofenadine and montelukast. He wants to know about how long one should use this, and the second part is, should we start initially at the initial stage of the disease?
So first of all, fexofenadine has been tested over years, and there is no, first of all, lack of efficacy, and there is no problem of safety. Montelukast is the same. So combining the two, I don't think that there is a problem. So I think that fexofenadine and montelukast can be given for a very long time. The second point is, when to initiate?
Yes.
Well, I prefer to start up and to go down. So start immediately by the combination instead of oral H1 blockers.
Okay. Any thoughts on that, sir?
Duration. There was a question. How long you can continue?
For a long time, he says, but can you make it 6 months, 1 year, like that?
Well, the studies have been done over 2 years. Of course, I don't know 5 and 10 years, but it is clear that these drugs have been used in millions of people for 20 years and that there is no problem.
Is there any curative value of this fexofenadine and montelukast combination? Can it cure if you use it for a long time, for 6 months, 1 year?
No, in fact, there is no cure of anything, possibly except immunotherapy. But for pharmacotherapy, even when you use a long time intranasal corticosteroids, when we stop them 3 days later, the disease is back.
So my question is, if it is not being able to cure the disease, whatever you give, fexofenadine or combination, then why do you recommend that you can use it for a long time, for 6 months or 1 year? Why not, when the symptoms becomes less or absent, in that case you can stop it? Why not?
Well, this is exactly what the patients do. When they've, by the way, who has allergic rhinitis in the room? Raise your hands, come on. It's not possible that no one here does not have allergic rhinitis. Raise your hands. Don't be shy. Okay. Who is taking the treatment regularly? You have the answer to the question. Not even myself, so you know.
Right, so Dr. Gautam, he wants to ask here is, what is your opinion about giving long-term antihistamine for treatment of allergic rhinitis in terms of helping in prevention of asthma or its exacerbations?
Well, it is known that cetirizine and levocetirizine do not prevent the development of asthma. So I think that there is no data showing that long-term treatment will be preventive of asthma. Long-term treatment is when patients have symptoms every day. As soon as they don't have symptoms, they stop. Don't you do that? Me too. I'm allergic to pollen, and by the way, I stopped my treatment coming to India because there is no pollen in India, and I have no symptoms.
So we have questions from the webcast centers as well. Dr. Virottam Tomar, he's the chairperson at Meerut. He wants to know the role of omalizumab in allergic rhinitis.
Omalizumab is very effective in allergic rhinitis. There is a major problem. It's the cost. If you think that 20% of Indian people suffer from allergic rhinitis, and if you give, I think, 10,000 euros a year, then the Bank of India will be very happy. It will be bankrupt. So the problem of omalizumab in the nose is that if a patient can pay, yes, but in my country, everyone is reimbursed. So the state does not accept that we give omalizumab in rhinitis.
Any thoughts on that, sir?
No, I don't.
Okay. There's one more question here on ARIA guidelines. Professor Buski, to you. Is ARIA guideline relevant for young pediatric patients?
Well, it depends which age, because the problem is that before 6 years of age, there are very few studies. There is one study on ripatadine, there are 2 or 3 studies with cetirizine, there are no clear studies with intranasal corticosteroids, there are no studies on Montelukast, they are only in asthma. So in very young children, first of all, the disease is different than in older children. After 6 years of age, we have plenty of evidence, and this is described in the ARIA guideline 2010. But below 6 years of age, we are missing studies.
What is the line of treatment for allergic rhinitis in patients less than 3 years with the recent changes in the guidelines and scenario?
Can you repeat, because I didn't catch it?
Management of allergic rhinitis in less than 3 years of age.
First of all, is it allergic rhinitis? Because, well, there are some children with allergic rhinitis. Well, one thing is, if the child is doing this, this is the allergy salute. So it's likely to be allergy. But if it is only sneezing or only nasal obstruction, very difficult to know. So if you have a child with such symptoms, you have safe drugs, which are oral H1 blockers. So give oral H1 blockers if they are effective. You are lucky. If they are not effective, you are not lucky. But there is a problem for the diagnosis and the management below 3 years of age. I recognize that, but no one is able to do the proper studies.
Okay.
I have a question. If it is below 2 years,
Yes.
you see, fexofenadine is not recommended below 2 years of age. So 6 months old child or 1 year old, in that case, what treatment you suggest
I think
for
that
allergic rhinitis?
in France, I don't know in this country.
Yeah.
In France, I don't know in this country, you can give cetirizine at 6 months.
But the company doesn't recommend that. You can use. Okay.
I say, I don't know exactly what are the labeling in the different countries. So I can say for France, I cannot say for India, but so it's the same.
So you use it in 6 months also.
Yes.
Yeah, okay. There's one different question out here on allergic or maybe the immunotherapy, which is much talked about. So this is Dr. Anandabrata Bose from Siliguri. He wants to know that they live in a place which is very close to the forest, that is doers, allergens, which are completely different from the city. So there are certain group of allergens which are completely different from the city. So how do we go ahead and develop a geography specific allergen or immunotherapy?
Well, the first thing is that allergic rhinitis is more, pollen allergy is more prevalent in cities than outside cities. So the pollens are moving around. So I think that we need to be global. Well, you do skin prick test of specific IgE, and if there is a positive skin test or IgE which is relevant with the clinical patterns, then you use this type of allergen. But I know that in India we have specific pollens that we don't have in Europe, and that you might have some difficulties with some extracts. But here, I'm sorry to say that I'm not competent enough to discuss it.
Do you prefer the oral immunotherapy or subcutaneous immunotherapy?
Well, my choice is sublingual. First of all, because the only good studies are in sublingual. Sublingual is really it's well documented, and it has been approved by FDA by EMA and by the Japanese regulatory, or the Japanese FDA. I'm sorry, I don't know what is the name. So this is approved and well demonstrated. So this is my choice.
Do you find ever any patient of refractory allergic rhinitis? Like sometimes you find difficult patients to treat with asthma.
Yes, it is.
So in that case, what do you do really?
Yes, this is the SCUAT patient. Severe chronic upper airway disease. And there are some patients who are really resistant. But what we do not know usually is whether the patient was compliant or not. It is why the cell phone system is quite interesting to understand whether the patient was compliant and what was the severity of the symptoms.
I'd like to ask something little different. So we find asthma patients whose even in active symptomatic state, IgE level is not raised. So maybe there are some patients, allergic rhinitis, in whom IgE is not raised. So how do you call them? Is IgE rise is a mandatory part of the allergic rhinitis diagnosis? If not, then what is the frequency of that and how do you treat that?
Well, as I showed you, the links between the nose and the lower airways are not only dependent on IgE. Only 38% of multimorbidity is explained by IgE in our cohort study. So there is a disease of the airways with an allergic disease on top. And so the problem is that treating non-allergic rhinitis is tricky because most medications are not very effective, as you know. And this is a problem. So what I'm doing, I'm treating the patient like an allergic patient. And if it works, I'm very happy. If it doesn't work, I had a fabulous way to handle my patients. I send them to the anti-doctor. So it was not my failure, it was the failure of my friends.
So adding to that, I would like to ask a question over here. Is there any role, of talking about serum Ig levels, is there any role of estimating it in diseases like allergic rhinitis, atopic dermatitis, or maybe asthma? Is there any role while
For total
planning the
Ig,
treatment?
no. For total Ig, no. For specific Ig, yes.
Okay. How long can intranasal corticosteroids is used and how safe it is to use?
Well, there have been at least 3 studies I know of 1-year trial, and we have done one of them. We did biopsies before and after because we are thinking that they could make some problem into the nose. In fact, this is not the case. The length, the duration of the treatment is patients-based. When the patients get better, stop. When they are worse, they continue or they reassess, So the problem of continuous treatment, do you have many patients? Well, among you have rhinitis. Who is taking intranasal corticosteroids daily for the year? Well, so it's not a major problem, since none of us do. But remember something. We are not compliant with medications and we ask our patients to be compliant. In your prescriptions, you write intranasal corticosteroids for 1 year. And you don't do that, and I don't do that. It's why I said, well, guidelines are good, but probably we need to be in real life.
There's one very interesting question which has come up, and I also request our audience sitting here in the physical location to think over it and share your opinion as well. The question is, treatment of allergic rhinitis in children, is it a job of a pediatrician or an ENT physician or a surgeon?
Well, it is the job of everyone, because if the disease is simple, it is the job of the GP, because you have hundreds of thousands of GPs in India, you have much less specialists, I suppose. So then it is the job of the pediatrician or the GP. If it doesn't work, if the child has asthma, it's the job of the chest physician. If the child has rhinitis, it's the job of the anti-doctor. And if the child has the 3, it is the job of the 4 doctors because then they should discuss together in order to bring the best management for the patient.
When do you ask for a paranasal sinus X-ray, and when do you ask for a CT scan of the paranasal sinus?
I never do X-rays because they are not very precise. So what I'm telling you what I'm doing. First of all, I'm treating my patient. Well, when I saw a patient, the patient had skin test and pulmonary function always. And then I treat the patient for a month. If after a month the patient is not well and has major symptoms of the nose, I send the patient to the ENT doctor who will eventually prescribe a CT scan. This is the way I'm doing.
Just a small question. Is there any sort of counterpart of allergic pulmonary aspergillosis as allergic rhinitis with aspergillus colonization or aspergillus induced enhancement of allergic rhinitis?
Well, this is an unresolved study. I am not an ENT doctor, and we have very little aspergillosis in my place. Well, it's, in London they have a lot, in France we don't have because of climate. I know that there is fungal allergic rhinosinusitis, and this is a much debated project because some people say yes, other people say no. And when there is a debate, it's very complex. And there is also colonization of aspergillus in the sinuses. So I think that this is a very complex area, and it may take 2 evenings to discuss. Any other question? Raoul?
Any other question?
Raoul, any other
Yes,
question?
there are plenty actually.
Okay, but
Okay, what
give
is
a
the-
summary because otherwise...
No. What is the highest possible dose of fexofenadine that can be administered in an adult, for example, in allergic rhinitis?
180 a day.
180 a day, okay. So there are certain questions which we have already answered, like what
Okay,
is
if it's
that?
answered, go ahead.
Yes. What is the minimum age group, or maybe the age, for glucocorticosteroids which can be started?
Well, in
Steroidal
France it is
therapy?
2 years of age with mometazone. Here I don't know.
Okay, and the age?
2 years.
2 years, okay.
Below that?
No. But below that, the diagnosis is very difficult. I think that you should go fast.
How do we manage a case of pregnancy with allergic rhinitis?
Well, this is very difficult because usually, yes, look, you said stop after that. Huh? This is a very complex question because usually women become pregnant before and they continue to take their treatment. So it's too late. But with the classical treatments we have, there is no major risk. I think that this is enough.
Yeah.
No,
Can we start any medication?
Stop.
This is the last question, we'll take it up. Can we start any medication in anticipation for acute attack of allergic disorders? As a prophylactic measure?
No.
Acute, okay. Okay.
Thank you.
Thanks. Thank you so much, audience here and at the live webcast centers. And I now request everyone to please join us for dinner.
My pleasure.